Um, First of all, I want to thank you for coming over and visiting the center that we have made. But Dr. Goswami, I have a couple of questions that actually intrigues me. One is the use of three-dimensional histopathology, which is absent in an Indian setting. Even though in many of the hospitals we know that we have instruments like confocal microscopy, but none of the pathologists are actually doing it. And the second thing is, several companies in the United States of America, like Precision Therapeutics, Static Oncology, all these companies, they have come a long way in predicting chemotherapy by using cell culture techniques. Now, way back in 2008 even, we had a long fight about the use of these technologies into actual clinical practice, because there are several papers which show that it does not give too much good results for the clinical outcome. Several papers actually show that they have brilliant outcomes. So what would be, and in India we do not have these facilities. We are trying to build this up, but we do not have it. So what would be your take on the use of these technologies, where you can actually pinpoint not only the first line, second line chemotherapy, not by genetics, but by the actual phenotypical behavior of cells?
Yeah, I think it's a very relevant question in the sense that three-dimensional pathology, histopathology is, you see, histopathology has to come of age, because at the end of the day it's the morphology which is the crux of the story. You can do n number of sequencing, you can do everything, but at the end of the day you need to know whether it's a squamous cell carcinoma or an adenocarcinoma or a small cell carcinoma or not. So morphology is the basis. So unless and until you do good histopathology, the molecular genetics won't be able to be a supplement to good histopathology. So I think that is a primary. And first it is histopathology, then it's molecular genetics. And as far as your cell culture technique is concerned, I understand we do not have level 1 evidence at this point of time, but there are certain other platforms also available in the country by other labs. They are doing it. It has always been an issue of bench to bedside. Now everything which is practiced in the bench do not seem to be as effective as it looked in the lab on the bedside. So there is a gulf. So I think the more we can minimize that, it's absolutely, you see, we have been able to do it in, I would say, microbiology. We know exactly what bug is treated, should be treated by what antibiotics, and that's why we have had an effective use of antibiotics. At the same time, we have had an effective misuse of antibiotics. We have actually gone into a post-antibiotic era, which is, I think, I shudder, because say for instance at the age of 70, if I get a nosocomial infection, probably I won't have any treatment. It's better to have a cancer than a nosocomial infection, because there are some treatments for cancer, whereas there would be no treatment for nosocomial infection. So I think there is a use and misuse of everything. Rationality is the most important thing. If we can develop a platform, develop a proper cell culture technique which will effectively simulate the tumor, what it is in the body on the lab, and show the effectivity of a particular chemotherapy drug, I think that would be wonderful. Because chemotherapy till today is a very cheap modality of treatment compared to targeted therapy. So majority of your cancers, the backbone of treatment would be chemotherapy. Targeted therapy would be an adjunct to chemotherapy. Most of the targeted therapy, if you look at it, they do not act alone. They act in combination with chemotherapy, except for small molecules and other things in lung and other areas. So if your chemotherapy backbone can be made more robust and more effective, where you can actually predict the outcome of tumor lysis, I think that would be wonderful. And that would make your targeted therapy, when combined with chemotherapy, more effective, because you will definitely get more cell kill. So I think that will end up giving you more response rates, better progression-free survival, and ultimately will turn into better overall survival. So keeping all those things in mind, I think long-term clinical trials, randomized clinical trials are required. Unfortunately, doing randomized clinical trials becomes very expensive, and once you start getting into this, the cost of the test becomes very high. So I think we have to have a rationality. We can do small pilot studies, prove it, have a proof of concept theory and prove it, and then use it on a large scale in practice to get sort of a phase 4 result, and then use it. If the Drug Control General of India approves that sort of a technology, I think that would prove wonderful.
No, but my take on this is a little different, because when I spoke to the who's of Drug Control General of India, what I understood is that because this type of tests are not actually test kits, so if there is a logic to it, even in India one can go ahead and do this test. As far as NCCN guidelines are concerned, in 2018 they have come up with gynecological cancers that in cases where multiple treatment options are available, these types of tests can be used. But for the others, I completely agree that we need to go with a robust clinical trials before we actually put them into clinical practice.
I am not too sure about that. We need to look at the legalities, but as of now, if my knowledge serves me right, because I am one of the PIs in this study, Mitra Biotech is doing a similar study.
CanScript.
And DCGI has asked for an 800 patients study. And they are doing it. They have accrued, yesterday they have accrued 400 patients. So they are halfway. Their target is to, by end of 2019, to get 800 patients. I don't know whether they will be able to do it. Maybe they will be able to do that. Offhand, whatever patients I have used in the clinical trial, though I don't want to comment on that, I have not been very excited in the sense, because first of all, there are certain limitations of the test. Every drug cannot be tested. So that gives me a drawback. I look at it as a handicap for the test. The other thing is that, what would I like to know? I would like to know the unknown. If I know that a breast cancer, the drug of choice is doxorubicin or an anthracycline, I don't like to test anthracycline. I know that they will have a response. I would like to test a drug, especially, and this becomes more effective in second line, third line refractory tumors where I am running out of options, and I would like to test a drug which I am unsure whether this drug will have an effect on the tumor or not, and I would like to use that drug, and if I get a sure shot answer, I would probably use that drug. So I think this sort of a technology is more useful in refractory, hard nut to crack tumors, second line, third line, or for that matter, not very chemosensitive tumors when you run out of options. You are scratching your head what to use. If you get an answer to it, that would be wonderful.
Thank you so much, Dr. Goswami, for that.
Most welcome. I think I wish all success to this endeavor. I think, and because you are doing it over here, you will be able to minimize the cost and help our patient population. Looking forward to it. Thank you very much.
Thank you so much.